Hello, everyone, and welcome to another edition of Contagion. My name is John Parkinson, and I'm the senior editor. Joining us today is Dr. Deepika Thakur, who is a pediatric cardiologist at Nemours. Dr. Thakur saw one of the earliest cases of multi-syndrome inflammatory syndrome in children and wrote about it recently in a journal. Thank you, Doctor, for being able to join us today.
John, thank you for having me.
Let's jump right into the topic. Take us through when this young patient first arrived at Nemours, his initial presentation, and how you finally arrived at your diagnosis.
John, that was a very interesting case, actually. And we were in the middle of the COVID pandemic, which, as you're aware, had started or declared itself on the East Coast somewhere towards the latter half of March. And so on April 12th, this 14-year-old boy presented to our hospital with abdominal pain, vomiting, and fever, and some diarrhea. And his initial symptoms made us suspect appendicitis. But when we worked him up for that, all our test results for appendicitis were negative. On his chest x-ray, he had some enlargement of the heart, which led to us doing an ultrasound of the heart that's called an echocardiogram. And on that, we found that his heart function was severely decreased. And so we treated him as somebody who has myocarditis or inflammation of the heart with intravenous immune globulins and steroids. And he also had low blood pressure or shock. So we had to start him on supportive inotropic medication for that. His initial testing for COVID was negative. So at that time, we were doing the antigen test or the RNA PCR test for the RNA of the virus, and that was negative. And so he received supportive management and did well. His cardiac function improved. He had mild dilation of the coronary arteries, so just a little bit enlargement of the arteries that supply the heart itself, and that resolved as well. And I think he went home in about 7 days. And then on April 24th, we saw a memo from the doctors in the United Kingdom alerting us to a syndrome that was emerging there, which was similar to a condition called Kawasaki disease that was presenting in teenage kids with abdominal complaints and cardiac involvement. And they were associating this with COVID-19. And so we were able to send antibody testing had just become available. We were able to send that on our patient, and it came back positive. And so retrospectively, we were able to diagnose him with what is now known as MIS-C or multi-system inflammatory syndrome in children associated with COVID-19.
And so when you were treating the patient, you didn't know at the time that, in fact, he did have COVID-19. And yet your treatment protocol seemed to work, and he was released from the hospital. Is that correct?
Yes, that is correct. Now, the treatment protocol, fortunately, we were, treating him with the same medicines that later were found to work in this condition. The difference being that at that time, these medicines were used, one after the other over a period of 2 to 3 days. And as we got more information and we had more kids present with this syndrome over the next few weeks, we were able to start all the therapies right away within a matter of hours. So that really helped to shorten their course and lead to early recovery.
And you said, doctor, that the patient had been released. And how is the patient doing today? And has there been any residual effects from his condition?
He's doing great. So he has no residual effects, from whatever testing is available so far. We have not yet done an MRI on his heart, which we plan to do in a few months' time to look for any residual defects on that. The family has been wonderful and very forthcoming with sharing their story, to get the message across to other parents and families across the country.
And that's a really good point and leads to my next question. For clinicians, fellow clinicians, and parents, what are some of the more common symptoms they should be aware of?
The most common symptom in this condition really is fever. And then they can have a constellation of findings which include, one or more of the following. So they can have conjunctivitis, they can have rash, chest pain and shortness of breath, some headache and confusion. And predominantly, a vast majority have abdominal complaints. So abdominal pain, vomiting, diarrhea, nausea. And then some of them have, some swelling of the lymph nodes or swelling of the hands and feet, but those are less commonly seen.
Now, in situations like that where the parents might be dealing with a child who is feeling these symptoms, would it be best to see their pediatrician and then have the pediatrician administer a COVID-19 test?
So not all these children test positive for the COVID-19 test as we know it, because that is testing for the RNA, for the actual infection. A lot of these children are getting these symptoms a few weeks out from the actual infection. So the initial infection may have been completely mild, and this is an immunologic response of the body to that infection. So some of them test positive for the COVID-19 test, but some of them don't. And we look for antibodies to the virus as a sign that they have this syndrome. And that takes some time to come back. So to answer your question, I think, yes, I think connecting with their pediatrician is always a good first step. If the child is otherwise looking well, then even a telemedicine appointment with the pediatrician to start with will help direct where they should go next. If the child is sick, if it's after hours, then definitely they should head to the nearest pediatric emergency room if the child looks sick.
Very good. And Nemours has developed a clinical pathway for early recognition and treatment of the condition. Can you tell us what those clinical pathways are?
So yes, we have a multi-specialty group that has been working on the clinical pathway, and data sharing very early on through even social media apps and internet-based platforms has been very helpful in figuring out quickly what works and what doesn't. And so we have had about 3 versions of the pathways so far. Our most recent one, actually, I'm really proud of it. It looks good. It gives us the clinical signs of how to identify these children, and then we risk stratify them into a mild, moderate, and severe category. And then we have recommendations for what tests should be sent, and when we should do the echocardiogram to look for the heart function, and then what treatment protocols and follow-up should be arranged for the patient based on each of those categories.
And in terms of your pathways, have you been sharing that with other hospitals or medical systems?
We have. So we've shared it with various hospitals in Delaware, New Jersey, Pennsylvania, and then also with our sister institute in Florida. We also have, there are papers that are being published about different pathways in different centers across the country. And so we've shared it with clinicians across the country, and we have access to other pathways from other institutions as well.
Very good. And just lastly, doctor, are there any other takeaway lessons from a clinical perspective when seeing these patients?
Yes, I think we have learned to be aware and vigilant of this condition. I think, the first step to diagnosing somebody is knowing about it. So I think we've crossed that hurdle now. We are all aware. The second step is not overdiagnosing it. So I think we have to be aware that we're not missing anything else in the process. Very early on in the process, I think there was a kid who presented with Lyme disease, and treatment was maybe delayed by a few hours while we embarked on the pathway suspecting MIS-C. So as we refine our protocols, we have, become more accurate in being able to diagnose the actual cases and then rule out MIS-C in cases where it's not relevant. Like I said, sometimes it really mimics appendicitis. And so one of our patients presented to us having had an appendectomy at an outside hospital. And then when they did the surgery, they found that it was not appendicitis. And that's when we started treatment and the child did well. So I think being aware, but also being aware that we shouldn't miss anything else is really important.
Absolutely. And doctor, thank you very much for taking the time today to discuss this important topic.
John, thank you so much for having me. My pleasure.